Can you start, no?
Yes, sir.
Good morning, afternoon, good afternoon, and good evening to all GAPU members, those who are on this platform. I am Dr. Sandeep Nijhawan. I am President of Indian Society of Gastroenterology, and it gives me an immense pleasure to bring greetings from Indian Society of Gastroenterology to all GAPU members, which is a huge number of all the physicians actually distributed of Indian origin, distributed globally. And we feel pleasure in connecting with you on this platform. As far as Indian Society of Gastroenterology is concerned, we are actually uh, a society of around 3,500 members, and we feel the pleasure to be connected with you. So we will start with the session. This session will have actually two talks, and both are actually clinically important for all the physicians around. The first talk will be how to manage chronic diarrhea. So I'd like to introduce Dr. Vishal Sharma. He has a great research background on this subject. He is very much interested in research in luminal gastroenterology. He is professor of gastroenterology at the Apex Institute of PGI Chandigarh. He'll be speaking on how we manage patient with chronic diarrhea. Dr. Usha has also joined, so I'll ask her to actually say a few words about the session.
Thank you, Dr. Nijavan. We are all very fortunate to have the president of Indian Society of Gastroenterology address the gathering, and it is wonderful to connect at a global platform with the physicians of Indian origin. It is always a pleasure to be in Connect. I have been on this program earlier on also. And today we have two very important sessions, which are simple, practical approaches to two common conditions. One is of a luminal pathology and one is of a liver pathology. So chronic diarrhea is quite often a vexing issue. So we have Dr. Vishal Sharma, who's an associate professor, who's soon to become an additional professor in the Department of Gastroenterology at PGI Chandigarh. He is keenly interested in the area of luminal gastroenterology and works on tuberculosis and IBD. And following that, we have another lecture on abnormal LFT, how to approach it, from Dr. Amit Goel. Over to Dr. Vishal Sharma to speak to us on approach to chronic diarrhea. Dr. Vishal, please.
Thank you, madam, and thank you, Professor Nijavan, sir, for the kind words of introduction. I hope my slides are visible.
Yeah, they are.
Yeah, visible.
So, as madam said, that chronic diarrhea is an important clinical problem, and quite often that it is a vexing issue for gastroenterologists and physicians. And in fact, it is diarrhea is a universal human experience. In fact, it is a bit of a surprise that we don't have diarrhea much more often than we have. In fact, daily, around 8 to 10 liters of fluid enters our intestines. And this is largely through secretions by various organs, and also dietary fluid intake that we have. And it is remarkable that our intestinal tract can absorb almost all of that, and it is a very small amount of fluid that is excreted. Now, when there is a dysfunction or an imbalance in GI function, that results in either an increased stool frequency or loose consistency, and usually both of them, which we term as diarrhea. Now, anything which is shorter than 2 weeks is usually termed as acute diarrhea, and anything which is more than 4 weeks is usually chronic. And in between, what we have is persistent diarrhea, which mostly is due to some of the infectious causes which I have listed here. Now, before one makes a diagnosis of chronic diarrhea, it is important to be sure that we are indeed dealing with diarrhea, and there could be some things which could actually mimic diarrhea. One of this is fecal incontinence, which patients are often not very willing to come out with this history, and they will call it diarrhea because of the staining of clothes. And therefore, it is important that clinicians inquire into it. There's another term known as pseudodiarrhea, which is basically more frequent passage of stools, although there is no actual increase in volume. And there are a number of causes which have been listed as resulting in pseudodiarrhea, one of which is hyperthyroidism. Another entity is overflow diarrhea, which actually is in elderly individuals who might have chronic constipation with fecal impaction, and there is basically an overflow because of bacterial digestion of the obstructed fecal products. And this again can easily be sorted out with a per rectal examination. Now, once we have the diagnosis of chronic diarrhea, then I think it is important to have some clinical strategy to evaluate these patients. And usually what we have is clinical classification, which utilizes one of these pointers. So either one could classify the diarrhea on the basis of mechanism, site of origin, presence of pain, or the pattern of diarrhea. Now, if we talk about the mechanism of diarrhea, then broadly, people talk about two distinctive patterns. One is secretory and one is osmotic. In secretory, either there is an excess secretion of electrolytes and water into the lumen, which may be because of certain toxins, or there is a problem with these receptors, which results in increased fluid in the lumen. But usually because these solutes are the usual solutes like sodium and potassium, the stool osmolar gap here is low. On the other hand, in the osmotic diarrhea, which is usually because of certain unabsorbed solutes, which may be something like unabsorbed fructose, sorbitol, or even carbohydrate malabsorption, there is an osmotic load in the GI lumen, which results in increased fluid. And because the solutes here are other than the usual solutes, you have an increased osmolar gap, and we will come to it. So basically, secretory versus osmotic. In secretory, we know the etiologies could be stimulant laxatives, bile acid diarrhea, certain endocrine or functional neuroendocrine tumors, which can result in excessive secretion of water and electrolytes. And usually, this diarrhea continues even when individuals fast. On the other hand, osmotic could be due to multiple things like magnesium-containing antacids, carbohydrate malabsorption, sorbitol intake, and this draws fluid into the colon, resulting in diarrhea, and usually this abates with fasting. So as you can see, the osmotic gap, the fecal osmotic gap, which is 290 minus 2 times sodium and potassium in the stool, is actually high in the osmotic diarrheas. But practically, one can understand that usually it is a combination of these things, and there are only a very few etiologies which have either pure secretory or osmotic diarrhea. Now, coming to the next, people talk about small bowel versus large bowel diarrhea. Now, the defining feature of these two entities is actually involvement of the rectum, and involvement of the rectum in certain etiologies of diarrhea disturbs the reservoir function of the large intestine, and this results in passage of small volume of multiple stools associated with rectal symptoms of tenesmus, urgency, and frequency. Now, on the contrary, diseases which usually impact the small bowel or the right colon do not have this more frequent passage of stools, but they have much larger volume of stool, and the rectal reservoir function is actually preserved. Malnutrition or malabsorption is actually more common with small bowel diarrhea. But of course, as we understand, certain etiologies of colonic origin, like microscopic colitis, could also be similar to what is traditionally recognized as small bowel diarrhea. And therefore, people often use the term large volume diarrhea for small bowel and small volume diarrhea for large bowel diarrhea. In fact, these are often the preferred terms these days. Now, coming to pattern of diarrhea. Now, one could be what is known as fatty diarrhea, which typically is described with chronic pancreatitis, where there is maldigestion because of loss of pancreatic exocrine function. And this results in lack of absorption or lack of digestion of fat and increased fat in the stool, and therefore the stool could be oily. On the other hand, other type would be the watery diarrhea, where typically there will be a lot of voluminous stool. And in fact, here malabsorption may occur across various macronutrients. And this is typically described with endocrinopathies, and even osmotic diarrhea would typically be a watery diarrhea. One another entity is the inflammatory diarrhea. Anything that has blood or mucus and fecal leukocytes in stool examination. And often these etiologies also have underlying pain. And examples for this type of diarrhea would be inflammatory bowel disease, GI TB, ischemic colitis, colon cancer, and diverticulitis. But if we actually look, then many of these patterns overlap. For example, diseases like celiac disease or Crohn's disease, which have ileal involvement, extensive intestinal involvement, would practically result in virtually all of these things happening together. Some amount of inflammation, some amount of secretory component, and of course, malabsorption of various macronutrients, including fat. So again, there is a lot of overlap. But again, in some of the situations, one could have a specific pattern. Now, pain is not typically a common feature of chronic diarrhea, but when present, it could be helpful in pointing to the underlying etiology. And typically, epigastric pain could be part of chronic pancreatitis or Zollinger-Ellison syndrome. Pain of small bowel origin could happen in diseases like Crohn's disease, tuberculosis, lymphoma, mesenteric ischemia, and complicated celiac disease, whereas a hypogastric pain, which is typically described as a cramping kind of a pain, and which is relieved with defecation, is largely a component of diarrhea predominant IBS, but could also occur in patients with ulcerative colitis. Now, before we go further, I think it is important to understand how various nutrients, especially the macronutrients, are absorbed. So we have the ability largely to absorb only the monosaccharides. So the dietary carbohydrates, which could be in the form of mono, di, or polysaccharides, need to be digested first in the intestinal lumen through various enzymes and converted to monosaccharides, which actually enter the enterocytes and then are transported to the portal blood. On the other hand, protein absorption is again initially through digestion into smaller peptides and amino acids. And this is mediated by proteases and peptidases. Once these small peptides and amino acids are formed, our enterocytes have the ability to absorb both of these. And eventually these are converted to amino acids in the enterocytes and then transported to the portal blood. Now, the digestion of triglycerides is more complex. And in fact, the fats, typically these are digested through a combination of mechanical and enzymatic processes, which involve lipases. And then there is formation of micelles through the bile acids, because these are insoluble. And these micelles help in transportation of monotriglycerides and fatty acids into the enterocytes. Again, inside the enterocytes, triglycerides are formed and they go to form the chylomicrons, which are absorbed into the lacteals. And one important thing is to understand that the medium chain triglycerides can actually bypass this entire process and can directly be absorbed into the blood. So they can be used when these mechanisms of digestion are somehow compromised. So if we look in the proximal intestine and the middle part of the small bowel, most of the carbohydrate, fat, and peptide absorption happens. Proximal small intestine is again an important site for absorption of iron, copper, zinc, and folate. And in fact, diseases which impact this region are associated with deficiency of these minerals. Now, ileum, distal ileum especially, has a very important role in absorption of bile acid and vitamin B12. And in fact, in terminal ileal resections, actually, these could be compromised, and these are functions which actually no other part of the bowel can take up. All of the intestine is involved in absorption of water and electrolytes. Colon usually does not have much of an absorptive function, but it does absorb electrolytes. And in situations like short bowel syndrome, it becomes a very important source of obtaining energy through the digestion of actually dietary fiber or the carbohydrates, which are actually digested into short chain fatty acids and which are absorbed and provide energy in these patients. So if we understand this, there are two important processes that happen. One is digestion, that is breakup of the digested nutrients into absorbable form, and then is the process of absorption. So the problem could happen at either of these two levels. Mild digestion is when there is an intraluminal defective hydrolysis, and malabsorption when the mucosa cannot absorb the digested products. So typically, it's not a clinical of much clinical relevance to distinguish this, except probably when we talk about fatty diarrhea. Now, fatty diarrhea could be because of problems with the pancreatic enzyme, which is in chronic pancreatitis. And then the triglycerides are not typically absorbed, and these are excreted in the stool. So the stool is bulky and usually well-formed. But let's say if this part is okay, the pancreatic enzymes are okay. And this results in formation of fatty acids that actually and if that is not absorbed through the lumen, so fatty acids, and then there are malabsorption of other nutrients through the lumen, so that results in more liquid stools, and actually fatty acids can also result in increased colonic water output, kind of a secretory diarrhea. So this is the difference largely between fat malabsorption, which is associated either with chronic pancreatitis or with mucosal diseases. So how do we approach chronic diarrhea? The first and foremost, it is important to establish the severity and the pattern of chronic diarrhea. So one could establish whether there is a significant volume loss on the basis of symptoms of volume of the stool which is passed, presence of thirst, dryness, or even orthostasis. Now, relationship of diarrhea with food could potentially distinguish osmotic from secretory. Passage of undigested food, which is uncommon, may represent either maldigestion or intestinal hurry. Features of passage of blood, urgency, frequency, or tenesmus could suggest underlying etiology and involvement of the rectum. One important part of this entire conundrum is to separate the organic from the functional. Presence of a recent history of onset of diarrhea, older age, nocturnal symptoms, weight loss, blood in stools, abnormalities in blood tests, especially hemogram, and elevated fecal calprotectin would usually point to an organic cause of diarrhea. Now, there could be other clues like a recent new drug which has been started associated temporally with diarrhea. Sexual history could point to underlying immunodeficiency. Past history of surgery could suggest underlying short bowel if there have been multiple resections of the small bowel, or a bacterial overgrowth which could be because of strictures or blind loops. Source of water eating out could potentially be associated with infective causes like giardia. And then excessive intake of sugar-containing juices, syrups, gums, etc., could suggest an osmotic diarrhea because of malabsorbed or unabsorbable entities which are present in these products. Now, coming to drug-induced diarrhea, which is often missed and not thought of, some of the drugs actually are very important causes of chronic diarrhea. And in fact, some of the drugs can cause diarrhea in more than 20% of patients, including OHAs. Certain other drugs would cause in around 10 to 20%, like antibiotics or SSRIs. And then there are some infrequent causes of drug-induced diarrhea, like olmesartan or iron preparations. So these are important to consider in every patient where we are evaluating for chronic diarrhea. Now, historically, certain features could point to malabsorption. Looking for carbohydrate malabsorption, usually because this results in formation of acids by bacterial digestion of malabsorbed carbohydrates. The features are flatulence, bloating, gaseous distension, and explosive diarrhea. On the other hand, passage of oil or stools which float on water could suggest underlying fat malabsorption or steatorrhea, and foul-smelling stool, which is usually because of sulfide-containing gases, usually suggests an underlying cratoria or protein malabsorption. Now, coming to clues on examination, so one could find features which are suggestive of malabsorption of macronutrients, but certain findings could suggest underlying diagnosis. For example, clubbing could potentially be suggestive of entities like celiac disease, where it could be in around 5% of patients. And then even IPSID, which is an uncommon cause of diarrhea. Presence of lymph nodes could potentially point to lymphomas or underlying GITB. Then there are very important cutaneous clues, which are uncommon, but if present, they can point to an underlying etiology. So for example, dermographism could point to underlying etiology. Macroglossia, for example, could point to amyloidosis. Flushing and wheezing could point to carcinoid syndrome. Dermatitis herpetiformis may suggest underlying gluten hypersensitivity. Then erythema nodosum and pyoderma gangrenosum could be part of underlying IBD. And then there could be clues to vitamin malabsorption, which may manifest as cutaneous manifestations. Now, coming to blood tests, so a routine battery of tests could suggest sometimes the underlying etiology. For example, anemia with a low MCV suggesting iron deficiency could potentially suggest celiac disease. A low alkaline phosphatase may point to a zinc deficiency. Then HIV serology positivity may suggest underlying immunodeficiency. Elevated HbA1c could suggest diabetic diarrhea. But then there are more specific tests for underlying etiology. So typically, antibodies to tissue transglutaminase, typically done with the associated IgA levels, may suggest underlying celiac disease. Now, hormone secreting syndromes, especially hyperfunctioning neuroendocrine or endocrine tumors, could be picked up with the appropriate marker, which is measured in the blood. So something like chromogranin A may just suggest an NET, whereas in a carcinoid syndrome, one could have an elevated HIA both in blood and in the urine. In certain etiologies like immunodeficiency, IgA deficiency, or CVID, the immunoglobulin levels may also be low. Now, imaging is actually not commonly used for all of the cases of chronic diarrhea. But if there is significant pain or underlying suspicion of inflammatory causes, it may be relevant to take up imaging investigations. And then something like a jejunization, and you can see that something like volvulae start appearing in the ileum. So this could suggest underlying celiac disease or malabsorption. Now, thickening of the bowel wall could potentially suggest IBD, tuberculosis, eosinophilic gastroenteritis, or IPSID. Then underlying cause of bacterial overgrowth could be picked up with imaging like strictures, diverticulae, or mesenteric ischemia. And again, imaging could help in the diagnosis of chronic pancreatitis in patients who have steatorrhea. Fecal tests are again extremely important. And here actually, the infectious causes can be picked up by routine examination or cultures. And in fact, nowadays, multiplex PCR could pick up uncommon causes, infectious causes of diarrhea, and may be needed when the cause is not clear. Now, a simple test like using a Sudan dye would pick up underlying steatorrhea. Fecal calprotectin could be elevated in inflammatory causes, including in IBD. A low stool pH would suggest a carbohydrate malabsorption. Fecal elastase 1 is suggestive of pancreatic exocrine insufficiency. And occasionally, when one suspects that there may be patient may be taking laxatives, one may want to do a stool analysis for various laxatives. Now, breath tests are actually very important for diagnosis of certain conditions, especially bacterial overgrowth. And the principle is that one administers substrates, for example, let's say glucose. So glucose would typically be absorbed in the small intestine. But let's say if there is a bacterial overgrowth, then rather than a normal absorption, actually the bacterial metabolism will happen, which will result in formation of acids and hydrogen. And this hydrogen can be detected in a breath test. Now, lactulose is usually used to look for orocecal transit because it is typically metabolized in the cecum. But in patients who have a bacterial overgrowth, there would be a peak of hydrogen, which will happen much earlier. And again, these tests can be used for a plethora of other conditions like lactase deficiency, fructose malabsorption. There are certain tests for even exocrine pancreatic insufficiency not available in India, and the CCAT test for bile acid diarrhea, again, not routinely available. The next step, of course, is endoscopy. In fact, which test to do first is often a very difficult question, and usually the clinical pointers suggest how to go forward. For example, if somebody has an iron deficiency with diarrhea, one would want to do an upper GI to look at the duodenum, and then one could find scalloping. You can see scalloping here, and then reduced fold height, typically described with celiac, but which could also occur with a number of other conditions like tropical sprue, giardiasis, amyloidosis, and eosinophilic gastroenteritis. The yellowish discoloration of mucosa could suggest underlying lymphangiectasia or even Whipple's disease, which is again uncommon, or Mycobacterium avium intracellular, again, in immunodeficient patients. Thickened folds could occur in conditions like eosinophilic gastroenteritis, IPSID, Crohn's disease, amyloidosis, etc. Now, histology can give us a diagnosis in some of the conditions.
Will you take now?
Sir, I can finish in maybe 1 minute or maybe a couple of minutes.
Go ahead.
Okay.
Go ahead. Okay.
So histology can again be conclusive in some of the situations like Whipple's disease, giardia. So in Whipple's disease, one could have foamy macrophages and pus positive inclusions, foamy cells with AFB positivity in avium infection. Then lymphangiectasia could suggest either a primary or a secondary, which could be due to tumors or TB. Eosinophilia could suggest underlying strongyloidosis or even eosinophilic gastroenteritis, and one could also pick up parasites. Now, villus atrophy again is not very specific, but typically seen with celiac disease, tropical sprue, and again a number of other conditions. Now, since I have maybe a minute before I go to this algorithm, I'll just show quickly a few cases. So this was a young female with diarrhea, anemia, which was iron deficiency. So we did an endoscopy. You can see scalloping and grooving. IgA TTG was actually undetectable and the IgA levels were low. So we did IgG DGP, and this was celiac disease in setting of IgA deficiency. This was another patient, similar age, recurrent episodes of diarrhea, stool examination, giardia multiple times. And you can see this kind of lesions, nodular lesions in the duodenum, and this was nodular lymphoid hyperplasia. The immunoglobulin levels were low, and this was CVID with duodenal nodular lymphoid hyperplasia. Another case, 62-year-old male with multiple comorbidities who came with recent onset diarrhea, and there had been the IgA TTG and all were negatives. There is scalloping, and actually the patient was on olmesartan, which had been started recently, and this improved once this drug was stopped. So this is olmesartan sprue. In another case, elderly lady came with 3 months of diarrhea and weight loss, change of taste, alopecia, and these nail changes. And you can see polyps everywhere, stomach. This is atrophy in the duodenum. You can see multiple polyps in the colon, and these were all inflammatory polyps. And this was chronic Candida syndrome. This is another case, 28-year-old male treated as ulcerative colitis, no improvement even with steroids. So you can see thickened folds in the duodenum, and this is the ileocecal area, again, thickened folds, all of them showing amyloidosis. And eventually, at the age of 28-year-old age, at this young age, this patient had myeloma. So I come to the algorithm. Again, it is very difficult to have an algorithm for an entity as complex as chronic diarrhea. But largely, you establish whether it's a chronic diarrhea with history. For persistent, you try to rule out infectious etiologies. First, an easy step could be looking at whether there are any alarm symptoms. In their absence, you diagnose DIBS or functional diarrhea. Recent intake of or new drug which have been started, one could diagnose drug-induced diarrhea. One looks for malabsorption using clinical clues as well as various tests. And if it is present, then you try to determine the etiology also. And again, what is the first test to do is usually suggested by the underlying clinical manifestations. For example, if it's iron deficiency, one would want to start off by excluding celiac disease. If there is a history of surgery, one would want to exclude bacterial overgrowth or a short bowel syndrome. If there is pain and bloody diarrhea, usually inflammatory causes, and one might want to go ahead with a colonoscopy. And if there is a suggested history, one may want to rule out HIV and opportunistic infections. If it is unclear, then it often demands an extensive workup and looking up for uncommon causes. Thank you for your attention.
Thank you, Dr. Vishal, for a masterly lecture on a very complex condition and quite often a vexing problem, as I suggested earlier. Just to reiterate for our audience, the commonest causes, if I say, for diarrhea, which we should exclude before we move on to others, is celiac disease, which is very simple to exclude. Secondly is inflammatory bowel disease, Crohn's, as well as ulcerative colitis, where calprotectin can help us. Thirdly is chronic diarrhea due to giardiasis. So always look for it, otherwise we will end up missing it. And as Dr. Vishal suggested, drug history is important to exclude drug-induced diarrhea. Irritable bowel syndrome anyway remains always in the back burner in these situations. And pancreatic insufficiency, small bowel bacterial overgrowth, and lactose malabsorption, unless we look for it, we will not find it. So a careful history, a systematic examination, and a systematic approach to investigation will often give us the clue as to which way to proceed forward. And we have a few questions. I think we'll take quickly 4-5 questions.
We can have questions at the end because there is another talk. So
okay, we can do that.
So
Sure, we can do that at the end. Dr. Vishal, please stay on till we finish the next talk. With this, it is my pleasure to invite Dr. Ashish Goyal from CMC Vellore, who will be delivering a lecture on approach to abnormal liver function test. It is such a common thing sitting in the OPD to find, and we have Dr. Ashish Goyal to deliver this lecture on a very important problem. Over to Dr. Ashish, please.
Thank you, ma'am. Thank you to the organizers for the kind invite. Am I audible and my slides visible?
Yes, yes, very much audible.
So the mandate for today is approach to abnormal LFTs, and what we will do in next 15-20 minutes is actually do a pattern recognition. How do we understand a pattern, and then how do we make a differential diagnosis for the same? So let me just start with the first case, and we will go back to these cases towards the end of the lecture. First case that we see commonly in our OPD is a 17-year-old boy who presents with incidentally raised bilirubin level. And you can see the normal values here given. This is of total bilirubin, direct bilirubin, alanine, transaminase, alkaline phosphatase, and albumin. And So normal values are here provided, and you will see here there is a high bilirubin, but the other values are normal. The second case that we usually see in outpatient is a short history in a young person, a 15-day history of low-grade fever, nausea, who presents with high bilirubin of 15, alanine transaminase, which is very high, but otherwise preserved albumin. The third patient that we will see is a elderly patient who presents with jaundice, pruritus, again of short duration with high-grade fever and a mass in the abdomen with a predominantly alkaline phosphatase, which is high. The case 4 that we see usually in our outpatient is a patient who presents with hematemesis and can be a diabetic with high BMI, a 50-year-old lady who presents with mildly raised bilirubin, mildly high alanine transaminase, but a low albumin. Case 5 is of a patient who is, again, a very short history of 5 days after a toxic intake, presents with very sick with altered sensorium. So bilirubin may not be very high, but enzymes are high and INR is grossly prolonged. So during this lecture, what we will do is, by the end of lecture, we should be able to list out what are the causes of jaundice, list out what are the differential features in this, major causes in each type, and an approach to cases that we have discussed. So coming to the bilirubin metabolism, as we are all aware that bilirubin is formed by degradation of hemoglobin, and this bilirubin, which is unconjugated, goes into circulation and reaches the hepatocyte, where it is taken up by this receptor OATP and undergoes glucuronidation and is ultimately converted into a conjugated bilirubin, which is excreted out into the bile duct. Some of this conjugated bilirubin, if it is in excess, can reflux back into the plasma through the receptor on the basolateral membrane. So if the problem is in the prehepatic phase, where the hemoglobin degradation or bilirubin uptake is a problem, this will be a prehepatic jaundice, which leads to unconjugated hyperbilirubinemia. If the problem is in the hepatocyte, this predominantly will lead to conjugated hyperbilirubinemia, because the rate limiting step in the hepatocyte is the excretion of conjugated bilirubin. So the preservation of conjugation is there in hepatocyte injury. So hepatic injury predominantly causes conjugated hyperbilirubinemia. Again, in the post-hepatic cause like bile duct obstruction, there is a buildup of conjugated bilirubin inside the hepatocytes, which refluxes out and therefore leads to conjugated hyperbilirubinemia. So bilirubin, we know, is measured by a Diazo-Vandenberg reaction, which is a colorimetric reaction, and a direct fraction is equivalent to conjugated fraction, whereas the indirect bilirubin is what is known as unconjugated hyperbilirubinemia. So to come to the classification of jaundice can be classified into 3 major types. I think one is isolated disorders of bilirubin metabolism that we have described. It could be because of liver disease, where the hepatocyte injury is there, or it could be because of the bile duct obstruction. As far as liver disease is concerned, again, as per pattern recognition, we can recognize a predominantly hepatocellular pattern or a predominantly cholestatic pattern. And I'll come to it in further slides. So coming to isolated disorders of bilirubin metabolism, these disorders of bilirubin metabolism just results in high bilirubin levels, but a normal liver function otherwise. So your enzymes like alanine transaminase, aspartate transaminase, synthetic function like serum albumin, alkaline phosphatase, prothrombin time, all of them are normal. Jaundice then can be in the isolated bilirubin metabolism disorders, can be either predominantly unconjugated, where more than 80% is indirect. This could be because of increased production of bilirubin, which is usually seen in hemolysis, decreased uptake, which can be seen in drugs like rifampicin, which affects the OATP receptor. It could be more commonly seen with defective conjugation. And this is very commonly what we see with Gilbert syndrome, which is indirect hyperbilirubinemia, with normal, otherwise liver function test. If there is a conjugated hyperbilirubinemia, which is more than 50% is direct, it is more likely a rare syndromes like Dubin-Johnson-Rotor syndrome, which is defective excretion of conjugated bilirubin. Now, coming to the more common causes of liver disease and bile duct obstruction, and I'll deal with more or less both of them together. This is how we interpret the LFT. So if there is alanine transaminase or aspartate transaminase which is high, this indicates injury to hepatocytes. Aspartate transaminase is a more non-specific enzyme, can be present in muscles and the myocardium as well, but alanine transaminase is more hepatocyte-specific enzyme. So an increase is indicating hepatocyte injury. Increase in alkaline phosphatase indicates injury to the biliary cells and so cholangiocytes predominantly. So if there is a predominant alkaline phosphatase injury, we are looking at biliary injury. Whereas albumin decrease or prothrombin time increase indicates synthetic dysfunction of the liver. These are the proteins which are produced from the liver and they have a half-life. So it indicates synthetic dysfunction and a more chronic injury in the hepatocytes. So coming to the pattern recognition in the liver disease, predominantly hepatocellular or predominantly cholestatic. So if I look at hepatocellular patterns, acute hepatocellular injury, this patient usually presents with a short history, with or without prodrome. And when we look at the LFT, bilirubin will be high, but if the predominant feature is the high ALT and AST, which is up to 5 to 10 times the upper limit of normal. Alkaline phosphatase generally is normal or maybe slightly high. Now, these are the causes most likely. What we are dealing with are viruses like acute hepatitis virus, like hepatitis A, E, or B, toxins like drugs or alcohol. And these are the causes. And once we recognize this pattern, we have to evaluate for the causes. As far as chronic hepatocellular dysfunction is concerned, these patients are generally symptomatic for more than 6 months with non-specific symptoms of weakness or portal hypertension-related symptoms. Bilirubin may be mildly high, but enzymes are not that high. So it is around 2 to 5 times upper limit of normal. A history duration of more than 6 months. Again, we have to look for common causes here, which is hepatitis B, C, alcohol, autoimmune liver disease, and others. So these are the common causes for acute hepatocellular dysfunction, and you can see hepatitis A, E, and B, drugs like antituberculous drugs for us, complementary and alternate medications, again, toxins. For us, it is rodenticide, but it could be any toxin locally prevalent, and we have to look for systemic mimics like malaria and leptospira in these patients. As far as the chronic, more common causes are concerned, these are hepatitis B and C, alcohol, and more recently, it is non-alcoholic fatty liver disease with metabolic syndrome. The other other not so common causes are Wilson's disease. Again, autoimmune liver disease, we have to look out for in most of these patients. Vascular liver disease can also present as altered LFTs. The other pattern that sometimes is seen in our patient is a patient who is presenting with systemic symptoms, say low-grade fever, weight loss, chronic cough, has a predominant raised alkaline phosphatase. And when we do an imaging, there is normal bile ducts. This is a pattern which we then say it is maybe suggestive of granulomatous liver disorders or infiltrative liver disorders like tuberculosis, sarcoidosis, or hematological malignancies. If the patient is presenting with significant pruritus and clay-colored stools, this is the pattern, and with very high alkaline phosphatase, this is a pattern of cholestatic liver injury, and here we have to look for causes with predominant cholestasis like drugs and primary biliary cholangitis. As far as bile duct obstruction is concerned, again, we'll move on to the bile duct obstruction. This can be both. The obstruction can be intraluminal, it could be in the wall, or it could be because of the extrinsic compression. Idea is to recognize a pattern of bile duct obstruction and then look for causes of this. Ultrasound or a further imaging should be able to clarify what is the cause of bile duct obstruction. Now, type of bilirubin doesn't differentiate the site of jaundice here, because both hepatic and post-hepatic or obstructive jaundice, both of them have conjugated hyperbilirubinemia. But what will help you differentiate is history taking. And we have pointers like a prodromal illness in patients with hepatocellular jaundice. If the patient has associated pruritus, you're looking at cholestatic liver disease. Either it could be because of the bile duct obstruction or the infiltrative liver disease. If there is suggesting toxins like rodenticide intake, we are looking at hepatocellular jaundice here. Some of the history things, history pointers like biliary colic, high-grade fever suggesting cholangitis, or prior biliary surgery, all point out towards the possible bile duct obstruction. On physical examination, anything to suggest portal hypertension like ascites, splenomegaly, or any chronic liver disease, stigmata like spinal angioma, all these suggest hepatocellular disease, whereas the presence of high-grade fever, abdominal mass, or a scar which suggests biliary obstruction, biliary surgery, suggests a possible bile duct obstruction. As far as the liver function is concerned, as we have already said, there is a kind of overlap, and predominant enzyme elevation, if it is ALT, AST, then it is a more hepatocellular pattern and liver disease. Whereas a predominant enzyme is more alkaline phosphatase, you're thinking of ruling out bile duct obstruction in this patient. Now, prothrombin time is elevated even in deficiency of vitamin K, which could be because of chronic bile duct obstruction. So if we are giving vitamin K in these patients and prothrombin time corrects, this suggests a possible cholestatic liver disease. The further tests to be done once we recognize a pattern, and this may give you a clue. So if you have hepatitis B, C, or A and E, one of these tests positive, then you're looking at liver disease. Whereas if the ultrasound shows dilated bile ducts, you are looking at bile duct obstruction. So after the history and physical examination, and once we have your LFTs, we will have a general understanding whether we are dealing with isolated disorders of bilirubin metabolism or we are dealing with bile duct obstruction. If we are dealing with bile duct obstruction, we are going into imaging route where we are doing ultrasound to start with, and if needed, a CT scan or an MRI scan, and then according to the cause, we intervene on the management issue side. If we do not have a bile duct obstruction, then we have to look for underlying hepatocellular disease. So if there is ultrasound showing bile ducts, we will go ahead and do an ERCP or other management as per the cause. But if there is no bile duct dilatation, but still you are highly suspicious of biliary obstruction, we will go ahead and do a further imaging, which is like MRCP or endoscopic ultrasound. The cause I am not dealing with here, and the cause will be depending on the cause, the treatment will be depending on the cause of the disease that is identified. Now I'm going to deal in the next 5-7 minutes about the cases that we had discussed. This is the first case we had brought up, which is a 17-year-old boy, who was found to have raised bilirubin incidentally. Now what we have looked at is this person has normal alanine transaminases, normal alkaline phosphatase, and normal albumin. So the only problem here is raised bilirubin, which is then putting us into a category of isolated disorder of bilirubin metabolism. This is, again, when we look at the pattern, this is predominantly indirect hyperbilirubinemia. So what we are looking at is either hemolysis or more likely Gilbert syndrome here, because the person is asymptomatic, but we have to rule out hemolysis. The second patient is a young patient who presents with a short history of jaundice with a low-grade fever and nausea suggesting prodrome. And when we look at the LFT, the predominant pattern here is alanine transaminase, which is more than 10 times the upper limit of normal, and alkaline phosphatase, which is not very high, which is almost on the upper limit of normal range. We have got direct hyperbilirubinemia here, so conjugated hyperbilirubinemia. So this suggests that possibly hepatocellular jaundice. A low-grade fever and a short history suggests acute viral hepatitis-like illness. So we have to look for acute hepatocellular injury here and look for viral causes like hepatitis A, E, or hepatitis B. Case 3 was a patient, elderly guy who presented with a short history of jaundice again. And alkaline phosphatase, which is very high, almost 10 times the upper limit of normal, with not very high alanine transaminase, so and significant pruritus. So we are looking at a cholestatic pattern here, but the patient has high-grade fever, suggesting cholangitis with epigastric mass. So we are suspecting a biliary obstruction here. So the test to do here is an ultrasound abdomen and proceed from there and see the cause and evaluate and treat the cause. The case 4 is a patient who presents with hematemesis, and if you look at the patterns here, this hematemesis suggests possibility of varices and portal hypertension, and there is a mild hyperbilirubinemia with a mild alanine transaminase high and a low albumin. This all suggests a chronic hepatitis dysfunction and a possibility of cirrhosis, and as a patient is diabetic with a high BMI in a 50-year-old person, most likely what we are dealing with is chronic hepatocellular dysfunction and cirrhosis secondary to fatty liver or NAFLD disease. A young girl who presents with 5 days after intake of rodenticide and altered sensorium, and if you look at the pattern here, altered sensorium suggests presence of encephalopathy and high bilirubin with very high alanine transaminase and very high prothrombin time. All this suggests presence of encephalopathy and severe coagulopathy, suggests acute liver failure, and in the history it suggests a rodenticide or toxic related acute liver failure. So to summarize here, the liver function is basically a pattern recognition. But we have to rely on our history-taking skills, physical examination, and very relevant investigations to assess the cause of liver dysfunction. We have to eliminate one by one various causes and to then evaluate for specific causes and treatment accordingly. Thank you.
Thank you, Dr. Ashish, for a splendid lecture on an approach to abnormal liver function test. As you all noticed that he kept on using a word pattern, and it is this pattern identification which is very important in interpreting liver function tests. So if you have the setting, if you have the LFT, and if you have the ultrasound, I think 99% of the situations we will get a approach to how to move further. So I would think the combination of the setting, LFT, whole LFT pattern, and the third thing is an ultrasound. I noticed that he did not mention about SGOT and or AST as we call it. Here, increasingly we were moving towards using only ALT. However, AST to ALT ratio sometimes has certain clues. Elevated AST to ALT helps in diagnosing cirrhosis as well as Wilson's disease, as well as alcoholic liver disease, so and infiltrative liver disease. So in such a kind of setting, OTPT ratio may be of use. Otherwise, ALT alone is sufficient. And with this, we would now move on to the chat box and take up the questions. We start with the questions to Dr. Vishal Sharma on chronic diarrhea. And Dr. Nijavan, would you like to take up the questions or shall I go ahead?
Yeah, we can go alternate. No problem.
Okay. So you can maybe do the liver thing. I will address these questions due to Dr. Vishal. Dr. Vishal, Dr. Arshdeep has asked, what is the duration of fasting to distinguish osmotic and secretory? Literature says 24 hours, but that's practically difficult. What is your view?
Yeah, I think Dr. Arshdeep has raised a very important question, because actually literature describes even up to actually 3 days. So and then there were later studies which talked about 2 days and even 1 day. But it is certainly prolonged fasting. people actually are admitted for even this to test response to fasting, and it is not just typically asking what happens whether you fast or not. So that is the reason I think the initial description of the stool osmolar test was actually to take take off this test of prolonged fasting. Practically, the pure secretory and osmotic are actually not very common, and in fact, most people would not end up doing either of these. What we rely more on is symptoms with a particular thing in the diet, whether excluding that helps or not. So yeah, I agree that it is slightly problematic because it certainly warrants a prolonged fasting, and it may be better to really use a stool or smaller gap rather than actually practicing this 24-hour fasting, which may be a bit problematic.
So I would think here, I would like to add practically what we are trying to see whether the patient swings from low volume stools to high volume stool with a relationship of diet. I agree with Dr. Vishal that if you go by the textbook, yes, we do need to do 24-hour fasting. But if the patient is fasting for about 8 hours, 12 hours, and there is a decrease in stool output, and the patient also says that there's increase in stool output on eating a heavy meal, so that swing also helps us tell us that there could be a problem. So moving on to the next question, we have how to do the stool examination test. Is it the random stool sample or early morning stool sample? Dr. Vishal?
So I am unaware of a comparative data on that, but typically we ask for a morning sample. That is the time you have the the typically people pass stool, and it has been described that because it is a sample which is kind of fresh and overnight it has been there in the rectum, the yield may be more, but I am unaware if there is any data to really support that.
I think it is just the practical component, but it could be in a patient with diarrhea, they can give it at any point of time. It is an extension from the urine culture where you ask for an early morning urine because there is a collection of urine in the bladder and allows better yield. But I don't think if it's stool, it is so important. Any stool sample should be practically okay. Moving on to the next question, when to suspect immunodeficiency syndrome in malabsorption?
Yeah, I think apart from HIV, which we all are aware when to suspect, and probably we test everybody. I think probably the question probably pertains to the other primary immunodeficiencies, and this would be when you have recurrent infections, maybe infections outside the GIT also, like sinopulmonary infections. And other would probably, I think, even in one thing which we recognize is that some of the inflammatory diseases are also associated with the immunodeficiencies. For example, IgA deficiency is more frequent in people with, celiac is more frequent in patients with IgA deficiency, even IBD actually. And then if there are, certain, let's say you're doing a biopsy, you find giardia again and again, you have treated, again you find giardia, or let's say you have typical nodular lymphoid hyperplasia. I think these are settings where one should certainly evaluate for immunodeficiency, especially IgA and CVID in the adolescent to adult age group.
So just to add to that, if you don't suspect, you will never find. So anybody in which there's persistent diarrhea, there's repeated giardiasis, always have your index of suspicion high so that you can pick it up. You have to do an immunoglobulin profile to pick it up. So there's a question from Dr. Shivani. At what point is imaging advised? Dr. Vishal?
Yeah, imaging is not a test which we usually do upfront, but certainly if there are features of significant abdominal pain, abdominal intestinal colic, obstruction, and you are suspecting something like, let's say, tuberculosis, Crohn's, you may want to do an imaging. Typically, history would suggest any underlying cause of bacterial overgrowth, But again, in imaging could point out to underlying strictures or blind loops. So these are the situations. Again, pancreatitis, again, if significant pain is there. So, and then largely, I think last would be when even after the initial battery of tests, you really don't have a underlying etiology. That's where one would want to do imaging.
Yeah.
Yeah.
Thank you for going on to the next question.
Yeah.
It's the last question to Dr. Vishal. Increased stool frequency of stools, normal consistency and pain abdomen since 3 months. Can we say it is IBS?
It could be IBS. Usually the history is much longer than that. But I think lack of any alarm symptoms, and certainly some amount of evaluation would be needed before labeling this as IBS. IBS, as I would like to point it out again, and stress is a diagnosis of exclusion.
Yes, thank you, Dr. Vishal, for answering all the queries which were raised. Over to Dr. Nijavan to take up the questions related to abnormal LFT.
Thank you, Ashish. It was a very nice talk, making it very simple. There's a question in the chat box, like after starting the ATT, after 4 months, patient develops jaundice. So we can say it as DILI if all other causes are ruled out.
Thank you, sir. As I understand, this person has already stopped ATT almost 4 months. So before labeling it as drug-induced liver injury, usually a time factor also plays a role. So if you have already stopped a drug 4 months back, unlikely it is we can put it on a drug-related liver injury. But
So patient is continuing to be on ATT. Patient is continuing to be on ATT and develops jaundice after 4 months of ATT.
Okay, yeah. So yes, then it is definitely if the patient is continuing ATT, then jaundice can develop even after 4 months of ATT. It's an idiosyncratic reaction. We have to evaluate for alternate cause, but we can put it as drug-induced liver injury and take appropriate action.
There's another question in the chat box by Ankita. How to differentiate between Gilbert's hemolysis and drug-induced jaundice?
The hemolysis should be apparent on the routine tests itself. So hemoglobin, retic count, MCV should be able to. I think Ankita was answering the cases, so maybe that is not the question that she was asking. She just put in the chat box.
And how to approach a patient who has come to you with, to the OPD, and there is asymptomatic elevation of the liver enzymes without elevation of bilirubin. So only transaminases are high.
Yeah. So bilirubin may hepatitis. So the history is sort of is helping you. Then if it is an acute illness and the enzymes are in the range of 10 times or 5 times upper limit of normal, it could be anictic acute hepatitis. And then accordingly, we have to work up towards acute hepatitis and its cause. If the enzymes are not that high and a chronic illness, then we have to look at a chronic hepatocellular dysfunction. So bilirubin is only one part of the LFT, and we look at the entire pattern. It may not be high in some cases.
There's a last question now, that in a pregnant patient having isolated direct type of hyperbilirubinemia, what could be possible?
Sorry, I didn't.
The alkaline phosphatase and the enzymes are normal.
In a pregnant patient,
Pregnant
okay.
female with a high bilirubin.
So pregnancy doesn't affect the interpretation of LFTs to a large extent. The alkaline phosphatase may be high in third trimester of pregnancy, but otherwise the interpretation remains the same. If there is direct hyperbilirubinemia and it is isolated, then you have to go down the isolated direct hyperbilirubinemia as I discussed and evaluate for cause.
Thank you, Ashish. Now I hand over to Dr. Sushil Jain for the final remarks.
Thank you, Dr. Sandeep. It was a great presentation. Both the presentations were great. And the question and answer session was very good because that shows the interest of all the participants in the topics. So I take this opportunity on behalf of GAPIO to thank the organizers, the ISG, to have this session. Both the speakers, moderator, Professor Gupta Usha, and you, Dr. Sandeep. I also like to thank the backend team and the IT team who has made this event possible. And thanks to my colleague, Mr. Jitendra, who has been instrumental in organizing all these communications. Thank you very much. We look forward for further sessions. Thank you.
Thank you so much. Thank you.
Thank you. Thank you, Dr. Sushil. And thank you, Dr. Vishal
Great
and Dr. Ashish for a very wonderful session.
Thank you,
Thank you,
Ashish.
ma'am.
Thank you.
Thank you.
Vishal.
Thank you,
Nice
sir.
presentation.
ma'am.
Thank you so much.
Thank you. Good night.
Bye-bye.